This lecture is going to take Chapter 70 and hone it down in about 9 slides. We're going to really just focus on the very obvious points of this chapter and not call out specifically any of the vaccines. I feel like that is something that can be addressed by each of you when and if you need to encounter this in your daily practice. The goal of immunizations is very simply the eradication of disease. Since the dawn of vaccines, especially here in the United States, many diseases have reached almost non-existent states, with the asterisk to point out that most recently there has been a resurgence in some diseases based on the fact that there are greater portions of the population that are refusing vaccines for various reasons. But in the United States, diphtheria, measles, polio, and tetanus are almost unknown. It's diseases that we don't even deal with anymore. And quite frankly, we're not looking at new ways to treat these diseases because vaccines have done such a marvelous job of eliminating them from the scape of our health history. Immunization rates for many routine vaccines in 2011 were noted to be 90% or more among kids that are aged 19 to 35 months. There's some interesting changes that are occurring in the world of immunizations. Data that is available that compares Medicaid patients to patients that are covered under commercial insurance plans reveals that there was a 4% decline in immunization rates for children in the commercial insurance plan groups. And one of the reasons for this divergence is the persistence of the popular but discredited belief that vaccines cause autism spectrum disorders. So that's something that as a healthcare provider, you're going to have to grapple with and sort of fight with, because your patients will potentially have very strong opinions and will find, I am going to use air quotes here, many facts that refute the use of vaccines. But any way you dice it, vaccines do a greater good for the population than any risk that they might confer to a particular group of people. With that being said, there is not good, sound scientific data that tells us that vaccines are involved in autism spectrum disorders or other various severe reactions that patients have noted and thus use as sort of reasons to not get vaccinated. With the risk of potentially stepping on some toes, I do encourage people to check out some of the anti-vaxxer public service announcements that are out there, because they very simply strip away a lot of the sort of emotional link that there is to people being passionate about vaccinating or not vaccinating, and they just lay out the facts. Jimmy Kimmel, if you YouTube it, had a very interesting, funny take on vaccinations, both his intro to and the public service announcement that his program put forth. And there was recently floating around on Facebook an Elmo anti-vaxxer public service campaign. So it's something that is a very, very heavy topic in social media, in doctors' offices, and I think it behooves you as a practitioner to do some research for yourself so that you can approach these questions and concerns from your patient population, letting them know that we have sound scientific data that vaccines work, that they prevent diseases, that the reasons people aren't dying of these archaic diseases is due to basically entirely vaccines, and that the risks and concerns that people hold are not founded in true science. So, immunizations act to confer immunity to a particular disease, and there's two ways in which this happens: active immunity and passive immunity. Active immunity occurs when we administer all or part of a microorganism that evokes a response. So when we put that microorganism into the host, which is the recipient of the vaccine, we stimulate the body's immune response, and antibodies are stimulated to protect the immunized person from greater exposure to the particular disease-producing antigen. So the antigen is any substance that causes your immune system to make antibodies. So when we give you a portion of that microorganism, we allow your body to recognize it and create antibodies, so that a greater load of that organism, when presented, already has the antibody attack mounted, and it just needs to be basically called to the forefront to do its job. Active immunity is retained for a prolonged period of time. So that means that it gives an individual protection whenever the exposure to the antigen occurs, which can be years down the line from the initial point of immunization. Active immunity does infer a type of immunity that can be boosted at specific intervals, because it's only natural that our immune response might wane over time. And so boosting it allows us to sort of reignite those antibodies and bring them back to their maximal disease fighting capabilities. There are three types of agents that are used in active immunity: inactivated vaccines, live attenuated vaccines, and active immunization. So in inactivated vaccines, we basically give killed virus that is not capable of replicating within the host, and the host is always the person receiving the vaccine. There is very little risk to the recipient, but in order to ensure lifelong immunity with inactivated vaccines, multiple doses are necessary. So we have to slowly build the antibody response until we reach the point where we've sort of called in all the soldiers to do the fighting of the antigens. Live or attenuated vaccines use an actual live version of the virus that has been chemically changed to decrease its virulence. And we can think of virulence as potency. And so sometimes we'll use virulence to categorize, for example, infections that are more severe or more difficult to treat. So if we think about attenuated to be synonymous with decreased virulence, it basically means that we're giving you a portion of the virus, but we're doing so in such a decreased quantity and decreased potency that we don't get a full-blown active infection. We get a small active infection or a decreased active infection following the administration, and in actuality, few adverse effects occur. Live attenuated vaccines tend to produce a superior response when we compare them to an inactivated vaccine, but by the end of the vaccine cycles, we get the same type of immunity at the end, of full immunity. And live attenuated vaccines do not require multiple doses. Active immunization then is a little different. This is when we use a modified product of an organism. So it's not just a decreased virulent strain of the virus, but it's a different sort of presentation of the organism altogether. And it's referred to as a toxoid. A toxoid is when we take a toxin or a poison of the desired pathogenic organism and we treat it so that it's destroyed in terms of its toxicity, but it is still capable of inducing the formation of antibodies. So these modified bacterial toxins tell our body still to create that response, but without any of the risk of the actual disease. And this is what we use for immunization against things like diphtheria and tetanus. So when we give our Tdap, and it does require periodic administration of booster doses so that we can continue to mount the full disease-fighting antibody effect. Passive immunity then occurs when the antibodies that one person has acquired are given to or passed on to people who have not had immunity to that organism. So this type of immunity is classically seen in newborns. They will receive in utero protection or antibodies from their mother via the placenta, and then that immunity is actually continued for babies that are breastfed. So that is why we can offer some protection, although it is not nearly as great as the protection that is offered with vaccines to our smallest infants who aren't yet capable of receiving vaccination. So one of the populations that's at greatest risk when we don't immunize our school-age children, our kindergartners, is that for those patients who have younger siblings that cannot be vaccinated, we can't rely on the herd immunity of some of the kids that are vaccinated to protect the population of people that are unvaccinated. Because while I may not be able to contract a certain disease, I can certainly still be a carrier to those that are around me, thus putting them at risk if I am not immunized or if I'm only partially immunized. Passive immunity can also be achieved through the injection of something called gamma globulins, which you might all be more familiar with in the term of immunoglobulin. At the hospital, we just strictly refer to it as IVIG, intravenous immunoglobulin, and that's a substance that is made from human plasma. So the plasma, which is made from donated human blood, does contain antibodies that protect the body against specific diseases. So when we give passive immunity through a gamma globulin, we give a temporary protection that is achieved to the same degree that the active acquired immunity provides. However, They don't infer or confer long-term protection because the antibodies that are given passively from mother to infant or via IVIG naturally break down and are eliminated from the body. So we can't rely on that as the sole source of lifelong immunization. A quick word on preservatives in vaccines, because this can also be a hot button issue. Thimerosal is a mercury-containing organic compound that was widely used as a preservative in vaccines to help with bacterial overgrowth when we have multi-dose vials, which is a very common way for vaccines to be available. But the thimerosal was removed from or was reduced to trace amounts in all vaccines in 2001, with the exception of the inactivated influenza vaccine, because of the concerns about potential neurodevelopmental pathologies in infants who might receive multiple vaccines that contain thimerosal. And because infants have an immature hepatic system, there was a thought that if they received an overload of thimerosal, they would be unable to adequately clear that product. So it was been removed from the vaccine preparations, and I even think at this point in time, I'm fairly certain at the hospital we carry a thimerosal-free inactivated influenza vaccine. So I'd like to venture a guess to say that it either does not exist or exists in very, very small amounts in any vaccine that is currently on the market. And so when there was that information that thimerosal had been received, there was thought that perhaps the thoughts that the preservatives in vaccines or that the inactivated substances like preservatives and vaccines would decrease kind of the worry about the risk of autism, but that hasn't really happened. It sort of seems almost to have taken a surge in the last couple of years. As a side note, there has been good published data that says that the risk of various autism spectrum disorders does not exist with the current formulations of vaccines that are available. So I would just encourage you to go out and find that information for yourself so that you can appropriately educate your patient population. Providers should adhere as closely as possible to the recommended vaccination schedules. For vaccines that require multiple doses, if we get off of track, it's not that the patient won't ever reach their maximal sort of antibody load. It's just that we have to remember that full immunity doesn't occur until all of the doses are administered. So if we're unnecessarily delaying doses, or if we're delaying doses just because we're not stressing the importance for patients to keep on the track that is set out by the CDC, then we're basically just not giving them full protection, so potentially putting them at harm's way, and then also putting those around them at harm's way if people around them are relying on those people to be vaccinated because they themselves can't be vaccinated. There are guidelines concerning the use of and the scheduled administration of vaccines, and they're available and should be followed and or referred to whenever there is a question or concern about vaccine administration. So I've provided the link here to the CDC website, which has vaccine schedule diagrams and then explanations of what to do if you miss a dose, special populations, exceptions, or inclusions, and other information just about vaccine administration in general. So these guidelines are revised yearly, and they do provide the standard of care that all practitioners are expected to provide. So it really does become your responsibility, if you're in the arena where frequent patient vaccination is part of your daily work, that you become very comfortable with reading and understanding the schedules that are out there on the CDC website. And they are very user-friendly. There are a lot of notes to those vaccine schedules, but if that's something that's going to be a major part of your practice, it's in your best interest to become familiar with that. Now, we classically think of vaccine dosing schedules to be things that are just outlined for children, but in 2002, there was a recognition that there was an increased risk of pertussis, pneumococcus, and other vaccine-preventable diseases in adults, and so a vaccine schedule was created and is also updated yearly for the adult population. So our final two slides here of the semester are going to talk about some of the myths, and hopefully we can debunk them when it comes to the administration of vaccines for certain patients. And then we'll just briefly talk about some obvious patient education points for patients that are receiving vaccines. So Oftentimes, people or parents will call and say, God, my kid is sick, we can't get them vaccinated. But a minor upper respiratory infection or gastroenteritis, so a little GI bug, with or without fever, is not an appropriate indication for withholding a scheduled vaccine dose. Now, if somebody's going to come in and get a flu shot, they can certainly wait until their symptoms have resolved to get that flu shot, but it's not something that they should push off for a long period of time. And I will say as a parent that if a child has a fever, the pediatrician's office is less excited about giving vaccines. However, in our adult population, provided you don't have any massive comorbid conditions like cancer or other situations which put your ability to mount an immune response at a lower level, then we should be able to give these vaccines without much concern. The concurrent use of an antibiotic is not a contraindication for receiving a vaccine, and I think these are important facts for practitioners to know because they are reasons patients will call in and either reschedule or cancel appointments. Pregnancy is a contraindication for receiving live vaccines, but it's important to note that if there is a pregnant member of the household, that does not mean that other members of the household cannot be vaccinated. So we can vaccinate basically everybody except the pregnant individual, which is helpful in some situations, particularly if there is a disease outbreak that is treated with a live vaccine, because then at least we've created a little herd immunity within that family. Family history of an adverse event or a history of seizures or a history of sudden infant death syndrome is, again, not an appropriate indication for withholding immunizations. And then a lapse in the immunization schedule does not, for all vaccines, require the entire series to be restarted. But referring to those immunization schedule footnotes on the CDC website will help provide clarity for how you get that dosing back on track. And lastly, half doses of vaccine are never indicated in individuals who had a significant reaction to a previous dose. In those situations, it might be best to contact an allergist or an infectious disease provider, somebody that can give you a little bit more guidance on the recommendation for what is the next best step. So lastly, some obvious patient education pointers for immunizations, which I don't think can be overstressed to people when they come in to receive a vaccine. It is your responsibility to highlight the benefit and risks of vaccines prior to their administration. Of course, we don't want to go overboard with either spectrum of that information, but the CDC website does have standard information pamphlets, and I do believe, I think it's by law, those have to be given to patients at the time that the vaccine is administered. Most vaccines will result in soreness of the area that the vaccine is administered. So in adult and children, adolescent patients, that would be in the upper arm near the deltoid muscle, and for infants, that's near the thigh. So some patients will find that a warm compress provides some comfort for the soreness, but it is self-limiting and subsides within a couple of days. It's also expected that general flu-like symptoms can be noted following vaccine administration, but again, these are typically very mild symptoms and they are self-limiting. Those standardized information pamphlets will point out what symptoms or reactions are considered alarming or high risk, and so pointing those out to a patient is helpful because then they'll be able to differentiate what they can stay home and treat with, for example, acetaminophen and rest and fluids, or what does need to be seen by a practitioner. So this was a very general PowerPoint, but it was just to point out some of the more obvious and more general points of immunizations. And again, I would encourage you to check out the CDC schedules for immunizations and look up specific immunizations if and when you have these patients and these situations present themselves in your clinical practice.